G'day, DevelopingEMers. Today we're coming to you from DevelopingEM Central, which is in Kiama on the south coast of New South Wales. And this is just a prelude to a video that we've put together about the Australian experience with COVID. As you know, we've done some interviews with colleagues and other DevelopingEMers from around the world over the last 8 months. And it's been fascinating and scary to hear their stories. We were a little reticent, if I'm honest, about talking about the Australian experience. We've had a pretty lucky time down here, down under. And, we didn't want to make people feel depressed or upset at their own situations. But we think that there's something to learn. There's something to be gained by looking at the pros and cons of the Australian approach to the pandemic. And we think that we've interviewed a number of sensitive people, intelligent people that have got particular views that could be interesting. Okay, so just before we kick off, I'd just like to thank a couple of people who helped in the production of this video. Firstly, Sanj Fernando, who conducted the interview. He drove all the way down here from his home in Sydney. It's about a 2-hour drive down all the way to Kiama, and it's always good to see Sanj, and he did a great interview, I'm sure you'll agree. Secondly, a colleague who has helped us in the past in Cuba, Brad Dreyfus, who's an emergency physician from Arizona, and he had a look at our production and just gave us a few pointers on how to make it a sensitive discussion, especially as he's in one of the hotspots for the pandemic at the moment. And he also agreed that this was an important discussion to have and that it had been done sensitively. So we hope you agree with that. And thirdly, our interviewees who will introduce themselves over the course of the video. Accompanying the video, we've got some liner notes because there are some aspects that may not be familiar to you about the Australian experience that are referred to by our interviewer and interviewees. And so they're more fully explained in text form, which will accompany the video. And we hope that that's helpful. And thirdly, I'd like to thank all of you for sticking with us at what has been a very difficult time for all of us in emergency medicine. We hope to see you all again soon. There are plans ahead in 2022 for us to coordinate with some African colleagues and get a conference happening over there. Still early days, but we'll keep you informed. And we hope that although this festive season is going to be a little different for most of us, that you can have a safe and sound festive season with your friends and family. Thanks again for all of your support over the last decade, and it will be good to see you in person as soon as it's possible. Thanks for your attention, and we'll let Sanj take over the interview.
Well, welcome, DevelopingEMers. We're back, and as you can see, Mark and I are sitting next to each other. And what a year it's been. We started the year with this fantastic conference in Colombia, which was actually somewhat cut short. The local conference was cut short due to the outbreak of a pandemic that was sweeping the world. And we're going to be talking about the Australian experience. So just to introduce them very quickly, I'll get them to introduce themselves. We've got Matt Bragg, Claire Skinner, and Peter Cameron. Matt, do you want to introduce yourself?
Sure, thanks, Ange, and thanks, Mark and Sanj, for inviting me to participate. So I am an emergency physician and retrieval physician, and I'm based in southwest Sydney. I had the impeccable timing to take on the acting director job at Liverpool ED in January, end of January, just before the pandemic struck. So my experience of being director of Liverpool, which is one of the largest EDs in Sydney, has been dominated by COVID to the exclusion of almost everything else. And I'm not telling anyone here anything that they don't already know about how much the pandemic has dominated all aspects of our working and personal lives. So we we are, at the stage now where things are beginning to wind down a lot of our sort of COVID preparation, and I'm happy to talk about some of the aspects of our response preparation here in Sydney. Yes, it's...
It looks like you're in your office at work currently,
yep.
trying to ring some of those changes in.
Yes, we're calling you from Liverpool today.
Fantastic. And we've also very pleased to be joined by Claire Skinner. Claire is an ED departmental director, but she's also in the same way that Joe Biden is president-elect, she is president-elect of the Australian College of Emergency Medicine, which is, to be honest, a far more prestigious role.
Yeah, I think so, Sanj, absolutely. That's the pinnacle of my career to date, and it hasn't even really started properly yet. So I'm an emergency physician in Sydney, and I work on the exact opposite corner of Sydney to Matt. So I'm the director at Hornsby Emergency, which is a middle-sized ED on the northern outskirts of Sydney. But it was an interesting position to be in at the start of the pandemic because we actually saw some of the earliest cases of COVID in Australia, I think just because of our local community and where their network is internationally. So I actually got quite involved in the local response, and I think that led to me being someone that was reached out to by the state government to come in and assist with the centralised response.
Fantastic. Thank you very much for joining us, Claire. And we've also got Peter Cameron, who many developing EMers will recognise from previous conferences. He's been a contributor and a track lead and a supporter for a very long time. But unfortunately had to leave the Columbia conference to assist the Victorian government in their response. Peter, you've got a very long list of titles. Can you fill us in on some of them?
Yeah, the main relevance to this discussion, I guess, is I'm the clinical lead for Emergency Medicine Victoria. So I led the expert working group for emergency for the Victorian response, as well as being an emergency physician at the Alfred Hospital as well. So it was an interesting time. And
last but not least, we have, Mark and myself. For those people who aren't familiar with DevelopingEM, we are two of the three co-directors. I was trying to think of the right adjective to describe us, but couldn't come up with one. Mark is the Director of Training at a rurally based ED on the eastern coast of Australia in New South Wales. And I work in Sydney with Matt as well as an emergency physician. So, guys, I wanted to start off by talking about if we travel through what happened in Australia with COVID, and certainly Matt and I and Mark, we all got trapped in quarantine around about the 19th of March on the way back from Columbia. That was when cases started to pick up. I wonder, Peter and Claire, while we were in quarantine, what was happening in the background?
Well, it was interesting, Sand, because the Evidence Review in Emergency Medicine, which is a New South Wales College faculty conference, happened at the start of March, literally the 1st, 2nd, 3rd of March. And while we were there, we heard about an outbreak at Ryde Hospital in Sydney, which involved several of the attendees, including the chair of the conference. And that was actually a bit of a sign that something was happening. So we shelved that conference's program and moved to a COVID program, including interviewing the Chief Health Officer of New South Wales as part of our program. So I actually think for me, that was the start of it. We'd sort of seen the news, but we didn't really think it was going to come. And I guess we'd had some warm-ups with things like MERS, which happened a couple of years ago, and we got all the warnings for MERS and we didn't really take it seriously. And then it eventuated into, nothing almost in my part of the world. And this happened and it was like, that's exotic and overseas and it's not really going to come here. So, and it was only when we were sitting at the conference when we heard that a colleague, like an emergency doctor in Sydney, had contracted COVID and had been put on, put into ICU, that we started to go, hey, this is real and this is something that's going to really come into our part of the world and affect our colleagues and our working lives.
Yeah, I mean, in Victoria, we were sitting back at that stage, looking at the Sydney disaster unfolding with the, cruise ship starting to happen, and all of a sudden, it was becoming real, as Claire says, as opposed to, say, SARS and MERS and the various other things that have happened over the years. What was most interesting to me, because I was sort of called into the health department, and they had these, the public health people were there with their epidemiological modelers, and they had these amazing graphs with sort of, the numbers going, they were talking about 100,000 new cases a day in Victoria. And, maybe 4,000 ventilated cases in ICU. So that was the sort of nightmare scenario that they were sort of talking about with the modelling. I said that's bulldust. That cannot happen. It's not happened in the history of mankind, and it won't happen in Australia. Nevertheless, that's what they started planning for in terms of, rather than thinking about the things that actually happened, they talked about they talked about the intensive care unit. So they weren't talking about community, they weren't talking about residential aged care, they weren't talking about old people needing hospitalisation, they were talking about intensive care beds. And so at that stage, we started to look at procuring literally thousands of ventilators. We still have those thousands of ventilators, but they came some weeks or months later. But they've probably got a little bit of dust on them. But that was the sort of nightmare scenario and the framing of the way we were looking at it when that sort of initial, late March period was being experienced.
Well, it's interesting to hear you both talk about MERS and SARS. And Matt and Mark, I know you've both been transporting really sick people around the country with New South Wales Ambulance during the SARS outbreak. What do you see as the most striking differences between some of the other pandemics that we've had compared to this one?
Yeah, it's a good question. I think that this one appeared more worrying to me personally than the previous two, and in fact we didn't really have a lot of problems with SARS or MERS in this country. I don't think we really
didn't have in retrospect, we didn't have a case. There was one case that we thought we had. And
equally, I don't think I was G'd up for a pandemic in either of those cases. The flu epidemic in 2009 just seemed to happen. We were seeing lots of sick people, and then it just went away again. And I don't know that we really learnt a lot of lessons from it particularly. I'm talking purely as a clinician with no administrative role, but that's just how it felt to me. Matt, have you got any perspective?
So I was an infectious diseases trainee during SARS in 2003, and that was actually a very different experience because I don't remember the debates about PPE. I don't remember the sense that we were going to get overwhelmed by it. I did look after a case in my role, and it just seemed to be a very, very different vibe. And to be honest, my reflection on that now is that the places that seem to hit COVID well were the places that had genuine experience of being overwhelmed by SARS because they had pandemic plans that were pragmatic and workable, as opposed to most of us who had a pandemic plan that's the sort of thing you do for hospital accreditation every few years but has never really been put into action.
I was actually in Hong Kong as the Chief of Service at the Prince of Wales when SARS took off. So I had a fair bit of personal experience of SARS. And I was genuinely worried that it was going to hit Australia in the same way that it hit Hong Kong. As it happened, it didn't. And I've always thought since it was pretty lucky escape, probably because we're an island and there was a lot less travel then. This time we're a bit unlucky with the Diamond Princess, and we're probably a bit unlucky with the hotel quarantine in Melbourne. If that hadn't happened, it probably would have been a fizzer, the whole thing for Australia. Like, it's interesting, just a few little breaches and you get an outbreak. I mean, I think what's really interesting is that we've actually been able to contain it, but we can talk about that later. But the point is that living on an island with a very good health system and a public health response is very different to the rest of the world.
Well, 2009 sticks out for me clinically. And I was working in intensive care at that stage, and I do remember seeing people who were my age or younger who were, ill out of proportion with their risk factors. And that, actually for me, my clinical experience of that was that I saw sick people then. My clinical experience of COVID, and I came from a hospital that saw sick people quite early in the pandemic, but it hasn't been the same extent. But the response to it has been much, much larger than we ever had in 2009. And I wonder because that's because flu's a familiar beast and we had a vaccination, so we didn't feel that frightened of it. Whereas with this, it was a complete unknown. And I also, just to mention probably an elephant in the room, I think there's a degree of racism about something that is believed to have originated in China as well, and maybe that coloured our response.
We had the Hong Kong flu.
Yeah, well, and swine flu was American, but it was never referred to as the USA flu. And the irony, I think, in Australia is most of our cases came from the US on planes.
It's interesting hearing Peter relate those early stages, because it's very easy to forget what the atmosphere was like, February, March this year, when there were predictions of really frightening wave of pandemic, and the early work did seem to focus on the intensive care response and how we were going to step up intensive care units and establish a number of ventilators. And it's hard now to cast your mind back into that environment back then. We were, Claire and I, in our respective hospitals, were impacted quite early. In fact, we at Liverpool had run an education day for our trainees, and the doctor from Hornsby had been an attendee at the training day, and then subsequently one of our registrars tested positive, and we saw the first of what for us were 3 outbreaks within our hospital, and we can talk about that. But the impact on staffing, particularly I think early on with the public health response, the contact tracing response being very conservative, it just absolutely decimated our workforce. And I think that, obviously there's been a number of hospitals around Sydney and around Australia that have experienced that. So that has been, I think, one of the real major challenges is how we sort of provide for, ongoing service provision in the context of having, in some cases, 20-30% of our staff furloughed. And Claire and I had some discussion around this early on as well about, how we can support each other and the other EDs. But
I think one of the things that Claire's brought up about the difference in response to influenza and this is another elephant in the room. Like each year we lose roughly about 1,000 people a year to the flu. This year we've lost virtually no one, apart from in the first 3 months of the year when there was a little bit of a summer outbreak. In addition, we've actually lost a lot less people to infectious disease. In addition, we've lost a lot less people to AMIs and strokes because they haven't had the flu. And so actually we've had a fairly big decrease in mortality across Australia because of social distancing and limitation of infectious disease.
So are you suggesting that we should bring this in as a social...
Well, it's an interesting thing. If you go to, many Asian countries, when they're sick, they wear a mask, all this sort of gear. I mean, I think they cottoned onto it a bit earlier than us because they've got much higher density living. I mean, it's a bit silly wearing a mask when you're out in the country and you're walking around by yourself. But if you're in a tram or a a shopping centre, maybe that's a good thing. I don't know. But like as a public health measure, we've probably saved more lives this year than road traffic interventions and all sorts of things that we do.
Particularly true in the paediatric space for me. Like, normally our winter would have been full of kids with bronchiolitis and kids with croup and kids with asthma, and we haven't seen it. In fact, we're just starting to see it now with the bad pollen season in Sydney. So it is quite different, isn't it? And I do think the mask thing is real. And we got told in New South Wales hospitals last Friday that we could take our masks off after having had to have worn them for months. And it felt a bit wrong. And it was like, why have we always come to work and not done this? And I think the other big thing that I hope the COVID has challenged is our Australian culture of presenteeism, because, I definitely have worked close to, not being able to stand up and a part of that as well is our rosters just aren't robust enough to tolerate people not coming in when they've got a cold. So I think there's a few things here that maybe are positive.
It's really interesting to hear this conversation. And for those of you watching this, you would have realised that Mark and I are not socially distancing.
Watch out, unclean.
That's where we are in Australia. Mark has been licking me on a daily basis to build up an immunity to one of the bugs I'm carrying.
But you're in your own bubble, you two.
Yeah, it seems to work. He's stayed healthy.
I'm wondering whose bedroom you're actually in at the moment.
But Mark, I wanted to ask you, you've been doing a whole heap of interviews with people internationally.
Yeah.
Just contrasting what we've heard so far to the international experience.
Yeah, so look, I was actually really nervous about having this conversation because I've spoken with colleagues, developing emergency medicine colleagues from around the world, and they're having a really tough time wherever I've spoken to them, whether it's the US, Canada, Nicaragua, Chile, Brazil, and we just haven't. And, they're getting sick, they're being admitted to critical care facilities as staff members, they're losing staff members. And so I really had to think twice about having a chat about how we're experiencing things here. From an outsider's point of view, it looks like we have been really lucky. To a man and to a woman, every person that I interviewed said, if there's any opportunity that you can avoid what we're going through by the measures that you're taking, whatever they are, go for it, because you really don't want what we're experiencing. So, I mean, I guess, Peter, you were saying that Australia's an island and that's substantially helpful, but I imagine that there really have been things that as a healthcare community and as a governmental strategies that have really worked beyond us just being isolated from the rest of the world.
I think going back to my days in Hong Kong when I was in the SARS epidemic, there are huge differences in health infrastructure that we don't even acknowledge here. We have patients in single rooms. We have, even when they're not in single rooms, they're sort of meters and meters apart. We have proper ventilation systems. We have proper sewerage systems. We have staff who are highly trained and professional and can take time off. The whole infrastructure, access to tests. I mean, like we can test everyone. We might complain that it takes 24 hours rather than 2 hours for the test to come back, but we can test everyone. We have access to excellent PPE, even though we complain that, we might want a higher level of PPE. And the governance is stable. We don't have staff that just sort of wander off or whatever. We have, permanent devoted staff who actually know what they're doing. So those infrastructure elements are critically important.
we were talking before about the difference in approach to this pandemic compared to other viral threats that we've had. Building on that base that we have, I guess, going around the room, what do you think have been the really substantial positives that we've learnt as strategies in dealing with something as, ridiculous as this situation is that we're in?
I can only speak from the Victorian experience, but I think in terms of managing, and you've got to remember this is an external threat. So we had nothing here to start with, and then something came in. So first thing is to stop it coming in, and to do that early. And again, we have because we're a long way from anywhere, we actually have the ability to do that. It's not like the UK or somewhere where they're like half an hour away. They have 10 hours flights and so forth. So we can actually anticipate bad things coming in. That's the first thing. The second thing is the quarantine element for visitors, if we want to have visitors. And again, we can discuss that in some detail. The third thing is having a public health infrastructure that's sufficient to track and trace and do those sorts of things, as well as the testing capability to, predict and follow up patients. And then I guess when people do get sick, having a workforce which is capable of managing, the whole thing around isolation, quarantine, PPE is you cannot have a breach. You have to have highly trained people who do it 100%, as close to 100% of the time. You can get away with sort of getting it roughly right a little bit, but the closer to 100% perfect you get, the less problems you have. And then the other thing that sort of came out as a result of an issue in Victoria, in Royal Melbourne particularly, was the idea that you can use temporary structures and some old buildings and things like that to chuck people in who are sick because, that's put them all up the dirty end sort of thing. That idea, I think, has been blown wide open and is really a really important lesson from my perspective. You want the best engineered buildings for these sort of people. And again, we're lucky in Australia. We can do that. We can have 7 exchanges of air per whatever and all this sort of gear, proper filters and proper airflows. If you're in a poorer country, you're not going to have that level of engineering. But if you do have the capability, then you should be able to build those sort of infrastructures or use those sort of infrastructures for these patients. If you're in a poorer country, I guess, the other thing that's been quite clear is open air, sunshine are actually pretty useful ways of reducing spread. And again, I think that's probably one of the reasons why some of the poorest countries have actually done quite well because they've used nature, which again has been shown to be pretty, if you look at what's happened, this is a seasonal disease. And if you look at what's happened in the Northern Hemisphere, it's quite clear that it spreads much more rapidly under certain environmental conditions.
Talking about testing, that's been one of the striking differences between our experience in Australia and elsewhere, and even in Belgium, where the caseload is pretty significant still. You require 2 or more temporally related symptoms to qualify for a test compared to Australia. And I know, Matt, we had a situation where our entire emergency department, whether they were symptomatic or not, was instructed to get tests every 4 days. The utility of that seems significantly questionable. What do you guys think about where is the middle ground and what is the right path? Matt, do you want to talk to that? Because I think that the remnants of that is still floating around Liverpool.
Yeah, well, again, when in early days of the pandemic response, there was concern about the number and availability of tests, and we even had a local billionaire buy a plane load of tests from China. But I think as the response has evolved and we sort of stood up a lot of the capability for testing, and to the stage where we're now looking at more broadly applied rapid testing, I think you can be critical of the response in terms of this asymptomatic testing. I think that's been done, in Australia at least, it's been done in the health setting, but also in other workplaces. And given as I said before, given the impact of losing a staff member testing positive, and then the impact on contact tracing and losing half your workforce, I think the motivation to do sort of asymptomatic screening made some sense. It was a burden on staff to administer and for staff to go through it. But I think when the situation we were in, and again, comparative to other places in the world, we got off very, very lightly indeed. But the situation we were in locally here at Liverpool was we've had now 3 staff outbreaks, and I think that's the sort of motivation for the asymptomatic screening that we did. But I'm interested to hear what Claire or Peter.
I honestly think that testing has been part of the secret to success in New South Wales. And I guess if you're talking to me about lessons from the pandemic, the biggest thing for me is reflecting on the different governance structures within probably New South Wales and Victoria, which were absolutely opposite. So New South Wales's health bureaucracy is top heavy and very, very centralised. And Victoria's health bureaucracy, at least from the outside, Peter, is quite decentralised. New South Wales got a fright very early with the Ruby Princess and went very much into a command and control mode. So we established a state health emergency operations centre. I guess the other big thing we had going in New South Wales, again, which is easy to forget now, is we'd segued in neatly from some of the worst bushfires we'd ever seen. So we already had the Emergency Operations Centre running, and we already had a sense of this not being a usual time in New South Wales. So we'd already had very, very heavily curtailed movements through the Christmas period last year. So it felt in New South Wales like we just literally moved from one disaster into the next one. I went in early just to give you an example, I went in to make some information videos for New South Wales Health as the lead of the EM response. And they filmed them all. And then they rang me back when I was in the car park and said, you have to come back and do them again because we forgot to take down the pictures of the fire helicopters in the background. So we literally had this weird year. And I think the centralised bureaucracy and the centralised emergency operations response worked well in New South Wales. And I think our governance system was set up to do that quite neatly. And I think probably in Victoria that took a little bit longer to roll into action. So I think that was a lesson. And I don't know that you necessarily need that top-heavy centralised bureaucracy for business as usual, but certainly in a disaster, it was very, very useful. I think the testing in New South Wales has a very, very strong public health system. So we have our Chief Health Officer is a public health physician. We have public health units at district level. We're very, very networked up. And I think, again, that was part of our success. I think something we should talk about in the context of testing, though, is the role of trials. So a lot of the asymptomatic screening approaches, and particularly we've had a sewage screening approach running in New South Wales as well. A lot of that was actually done on an experimental basis. And I think, again, in New South Wales, probably everyone was very nervous, and it was not only an opportunity to do the research, but also a genuine line of inquiry around what is the best way to do this. And we're well placed to do it. Like, we have a strong scientific infrastructure in New South Wales, a strong governance system in our health department. And I was seen probably as a community service to start trying to do this. So I think, there's a number of things there that were really helpful. I do think, though, that the Ruby Princess happening early, so having a big breach of quarantine very, very early in New South Wales meant that we literally went into disaster mode much earlier than the rest of the country. And that was good because we did start testing. And we did start putting people into full PPE quite early.
I think Claire brings up a couple of interesting points that I didn't touch on. One, that the governance is important, and I think a command and control setup is important, and is not, as Claire says, is not the way that Victorian acute health normally runs. It's very much based on regional health services. And our public health infrastructure, I think everyone would agree, had been run down a little bit, which meant it took a while to tool up. But probably, I think, in terms of the overall Australian success, it's the governance side, but more importantly, it's the community engagement. And as Claire says, in some ways, we're almost primed for a disaster with the bushfires. People were almost sort of like in a state of emergency before the emergency had begun. I'm blown away by the fact that Australians who would think of themselves as more larrikin and independent souls than Americans have been willing to accept what is effectively a police state in Victoria for 6 months. That has blown. I mean, I would have expected some form of rebellion beyond a few half-wits, but, like really, I'm surprised that the Australian public has accepted this degree of civil restriction. And yet, when I speak to people on the street, they're accepting of it. They say, "Yep, that's worth the limitation."
Across Australia, there's been wide acceptance of lockdown. There's been wide acceptance of social distancing and wearing masks. There's been runs on both toilet paper for some reason, but also hand gels. Why do you think that is? Why do you think that Australians have been willing to accept it when many other countries in the world haven't?
I was just going to say, to pick up on Peter's point, that, as a broader socio-cultural sort of position, we like to tell the mythic narrative to ourselves about being the sort of larrikin, bushman, independent, rebellious to authority. That's our self-narrative, but it's just not true. I mean, we are amongst the most sort of law-abiding and rules following people on earth, and so we've got this sort of dichotomy where there's an idea about ourselves and then there's reality, and I think that's played into absolutely the response, and we've seen it also with our state governments really garnishing a lot of sort of political support for being very, very tough on border restrictions and social distancing and all these other measures. Almost, they're playing into a very receptive population who like people, their governments being very tough on border closures. Even when the evidence for them is really not that solid. So it's just an interesting sort of commentary on the Australian psyche that I think has been really shown up during this pandemic.
Because I've been reflecting on this too, and I've been worried about the growth of individualism in Australian culture. It definitely feels more individual now than it did when I was a kid in the 70s, which was a much more collective vibe. But I think we actually are much more community focused and collective than we thought we were. And it's probably actually written into some of our structures. I do think some of the state leaders got away with it because they played to parochialism, which probably hasn't been the strongest way of going about it, but it's worked. And I've also I've done a number of talks with international colleagues through the pandemic, and I remember one doing a talk on infection control with a colleague from Vietnam. And actually the people in Hanoi were much more accepting of full lockdown measures than the Australians were. So we're on a spectrum here. But I think we also need to reflect on 1919, which is, the biggest flu pandemic in our, collective, documented memory, I guess. And probably Australia did that one well too. And we did it because there were much lower expectations of personal freedom possibly then. Like, people were sent to quarantine camps and for quite a long period of time. So that, we are on a journey in terms of our culture and our history and where we sit on the individual versus collective approach to problems. And Australia's really pulled together in this. I think another thing to talk about though is the importance of good communication. And also making sure you just don't communicate with the majority, because we've seen some of the problems, particularly in Melbourne and housing commission estates, where some of them are minority communities, and I know that's not a great term, but they weren't engaged properly. And I do feel in New South Wales that a very, very good effort was made early on to actually engage with people at different places on the socioeconomic and sociocultural spectrum in terms that were, engaging. And that's And, you know, I'm not saying that we were perfect, but I think a big lesson is as well that if you want to take everyone on a journey, you've got to make sure you are genuinely talking to and working with the right people.
I think one of the things about a pandemic is it lifts the scabs off some of the sores. You know, like if you look at where we had trouble, you know, Victoria is the sort of pariah state in terms of the pandemic. And I think we're unlucky, to be honest, but it did, once the genie got out of the bottle, there were a number of areas where it was quite clear that social issues were actually the problem rather than the pandemic. And what I'm referring to here is, in particular, the hotel quarantine, where, fair enough, a untrained guard didn't do the right thing. That was poor training, and call it what you like. But then why did that then go into a spiral of problems? And if you look at it, this guard was doing multiple jobs. His family were doing multiple jobs, much of which was undocumented, much of which was probably, and I don't know the details, so, but much of which was probably, untaxed, undocumented in terms of all the sort of rules and regulations. And so they didn't necessarily give the contact tracers the full story. And this has been borne out in other scenarios, even as late as a couple of weeks ago in South Australia. But that side of it, in terms of the way we manage the contact tracing, is critically important. And the other thing that it brought out was places like abattoirs and processing factories don't have good infection control. And again, I think that's something we need to look at. And most importantly, in terms of deaths, was residential aged care, complete schmozzle. And if this had happened, the reality is this was a disaster waiting to happen in every state, not just Victoria. Once it's in the community, it gets into residential aged care. And our residential aged care, it's not that bad compared with many countries, but the problem is the way the workers work. So they work across facilities. So once it gets into one, it goes to another, because they often work across 3 or 4 facilities because they're poorly paid and whatever else. And they don't want to tell people that they're working across multiple facilities. And of course, they're often poorly trained because they're the lowest paid and all those sorts of things. So it really, we've had an aged care Royal Commission. I think there's going to be massive changes to the way we do residential aged care. So in lots of ways, it's a positive. As I said, it picks the scab off some of our worst parts of our society, and actually gives a chance to refresh and relook at some of those difficult areas.
Well, that's a really important point. The pandemics aren't fair, are they? They impact on the most vulnerable the most. And I'm really privileged. Like, I've actually had a good pandemic. And but I'm really aware, if you look at the difference between us and the US, the biggest difference, I guess, is secure employment. So here we are in Australia with universal healthcare, minimum pay, admittedly probably not generous enough. We had an increase in our dole payments through the pandemic, which is gone now. We had government support for businesses to keep them afloat during lockdowns. It's not perfect, and I guess it highlighted, particularly in the hospitality and aged care industries, that the people with insecure employment were the people who were the most vulnerable. But actually, our social conditions generally in Australia had set us up to do fairly well. And they've highlighted the bits where we need to start doing better to try and make things more secure for people.
That's really interesting, but I think Australia's also had another challenge that has been somewhat unique across the world, which is as you've all described, we got geared up for a pandemic, which kind of arrived in fits and starts, but for wide swathes of the country, they've seen no disease. And certainly, Mark, your ED has barely seen any COVID at all. How do you keep vigilance up? How do you stop people being lax? How do you continue to be prepared?
by following the rules like a good little Aussie, I guess, wearing my mask, going to the hot zone, not complaining. But you look at, where I work in emergency, we saw some cases, in fact, just before I got home in March, in ICU, and we have tested the hell out of the population ever since and not got a single other case, only 200 kilometres from a major metropolitan Sydney situation. So, there's been daily frustrations. I think it's been an annoying year, but it's been refreshing talking to colleagues overseas and just realising that, look, you've got it so good, you shouldn't complain, really. And so that's the way I've approached it. In my situation, it's been an annoyance rather than a danger. And we really thought it was going to be overwhelming and potentially dangerous to staff. And in my setting, I've been extremely lucky, and I am incredibly grateful for the steps that were made in a hurry, it appeared, but effectively to, protect patients and staff. But I guess everyone's had different experiences, but that's been mine.
COVID fatigue is a really real thing, and I think vigilance is hard through this phase of the pandemic, and it is just about culture in your department and training and keeping everybody sort of emotionally afloat, because I think even though we've got off lightly, I think it still has been a year of massive cognitive overload, rapidly changing guidelines. Just going to see a patient takes about 3 times as long. It's been really hard. I think, though, another thing that I think is worth raising in this forum is that I think we've never actually taken infection control very seriously in emergency medicine before. We've had that magical thinking that a patient with MRSA can't go to the ward because there's no isolation room, yet a pair of plastic blue curtains in bed 14 keeps them magically separate from the rest of the department. And I've never worn a mask to go and see a kid with bronchiolitis before, or a kid with croup. It's just been part of business as usual. So I think this has highlighted for me that in emergency medicine, hopefully now we do start to get better at infection control. And the biggest factor for me, I think, is a risk for us is overcrowding, which we all tolerate as usual. Waiting room medicine is usual for us in EDs. And I think this has to stop, because we can now see not only is it a risk to our decision making and it threatens patient dignity and it's horrible for the patient experience, but it's also a massive infection control risk that we have heaps and heaps of people in crowded corridors and crowded waiting rooms, and that's normal. It shouldn't be normal anymore. We need to actually create systems to stop that.
I was just going to say there's a number of really positive things that have come out of the pandemic, and how we work, and it would be nice to think that some of these can be sustained. And the awareness of infection control and PPE, Claire, is one. I think the other thing that we certainly experienced here at Liverpool, and I'm sure you experienced in your own hospitals, was an amazing level of professional engagement, support, collegiality amongst the different departments and different craft groups. So that was, I guess it's sort of that wartime mentality, but everyone literally did pull together, and it was really gratifying. We found that a lot of our response was coming from the clinicians as a ground-up response. We felt that, without getting too political, we felt that the response from the district and from was fairly slow. We set up a clinician-led COVID task force for our hospital, where a lot of the decision making was derived. We brought in experts, we brought in administrators and so on to support it. But it was very much a clinician-led response, and I think we were much more sort of nimble in our response because of that. So I think reflecting on this year, it would be great if some of these really positive outcomes can be sustained, and I'd be interested to see or to hear from you about your experience in that regard.
But one of the things I think we haven't discussed is the effect on mental health, which has really taxed us in Victoria. I don't know whether it was as bad in the other states, but we monitored very closely at a state level presentations and complications and all those sorts of things. What's quite clear is emergency attendances went down by about 30% in the middle of the lockdown and so forth. they're now back up above normal. But the mental health, actually initially the numbers improved initially. I think something like the Martians are attacking or something, somehow or another makes people feel almost better because they've got a common external enemy. But once that settles down and there's this prolonged period of social isolation, I think there's real issues at a societal level, and especially in the pediatric group. Like anorexics went up 3 times, for example. But the overall numbers of mental health actually stayed, as you look at a total number, stayed the same. But within that, there was quite a lot of movement. So obviously there was less drug and alcohol from, the party goers and stuff because there was no parties. But the people sitting at home looking at their navel, those people actually, there was a high level of anxiety and depression. And what's happening now is that's going up even higher. Now they've got access to more drugs and alcohol. And so we've got this sort of, I think we're going to have a bounce back of drug, alcohol and mental health problems. The other thing that happened was what we call code greys and code blacks. Physical violence against staff went up because of these increased mental health issues. Some of that was actually partly because of government policy. They had early prisoner release and so forth so the criminal psychs, those sort of people, because they were trying to empty out the prisons. But some of it is because of mental health facility capacity. And some of it, I think, is just because these sort of situations make people more anxious and agitated. So very interesting demographics and epidemiology of mental health during this period of time.
So that actually echoes both my clinical and the research experience in New South Wales as well, which is a rise in eating disorders, an enormous rise in domestic violence presenting to the emergency department, and the drug and alcohol epidemiology changed substantially. So something you have to remember in Australia is the vast majority of our opioids are imported, so they couldn't come. So we started to see other stuff getting used that was more home cooked. I saw some GHB happening, which I hadn't seen for about a decade in New South Wales EDs, and amphetamines on the rise because they're home cooked. So a big change in what we're seeing.
Yeah. Do you think it's the mental health issues were purely related to I'm in quarantine for six months and I've got nothing else to do than perseverate about my problems? Or do you think it was the overwhelming fear of the community, I'm too scared to go outside because I
think it's mostly the social isolation. I don't think we should, we were joking before about how, or not joking, but discussing before about, maybe the public health measures should be kept in place forever. The downside is the mental health side. I mean, humans are social, and if you put them in social isolation, they don't do well. So we've got to get that balance right. And certainly, a short, sharp lockdown of 2 weeks, no big deal. A prolonged lockdown is I think dangerous from a mental health perspective. So we need to, that's something to sort of reflect on, I guess, as to, what degree of restriction do you actually need? Because some things, like maybe it's okay to allow people to talk to each other and stuff as long as they wear masks and so forth. So there's probably a little bit of work to do on what's safe, even though you might be socially distancing.
I think also the world of work has changed enormously, and for a lot of people, work is their identity, or at least a large part of their identity. And if you're someone that's had a life of going into the CBD and working, with your colleagues and going out for lunch with your colleagues and going to conferences, and that's a privileged, inner city life, but it's very strange to suddenly find yourself at home with your family in the suburbs working on Skype. And I think the other little thing I worry about is the loss of physical fitness for a lot of people. Like, so the privileged people in Sydney have taken to ultramarathon running and kayaking with a vengeance. But that's not everybody's experience. And I think, you know, the COVID kilos and the COVID, I think there's a loss of COVID mojo, which I think we'll see for ages. And I do also wonder about the impact on kids. I've had a son in kindergarten at school this year, and that's a bit of a big deal. It was a big deal to go to school for 6 weeks and then have a term off, although he's bounced back. But I think at any of those transition points, like year 12 or first year uni, that'd be really hard. What do you think of your future if, you know, you're thinking, I'm not going to get a job, when I do get a job, it's going to be insecure or at home? And I think the rise in child and adolescent mental health that we've all seen through the pandemic reflects that lack of certainty about what the future holds. And I also wonder about my kids. Like, they've just had a year of being told that you're not allowed to touch your friends, which is very, very different to my experience. I don't know what that's going to do for their long-term mentality. I think about my grandparents and the depression. They carried that with them for their lives, that experience. And I wonder what the pandemic will do to the kids.
Yes. Just one thing in terms of mental health that's important is the suicide. So actually suicides didn't go up. In fact, they went down in the middle of the pandemic. They're about normal now, inverted commas. But it's interesting, despite all this anxiety and depression and so forth, the extreme version of that hasn't eventuated. It may be in 6-12 months it goes up. I don't know, but it's just interesting.
I think there's been a bit of life simplification too. Like, it's been quite nice not having to go to soccer and ballet and all that stuff. And also, you know, I've only really been trying to socialise with the really inner circle. I think we all do a round of going to everyone's houses on Friday and Saturday nights because that's just what we do, and a bit of that's broken. So in some ways, being at home doing jigsaw puzzles with your family has been okay, just not forever.
Yeah, and ordering in, yes, rather than eating out. Mark has written down a question for me to ask, and I guess in light of what's happening in America at the moment, where there seems to be a very significant third wave with peaks much, much higher than the first or second wave, we have very different political responses. And Joe Biden was out telling people not to go to Thanksgiving gatherings or just gather in small groups and encouraging them to wear a mask. Donald Trump, in counterpoint to that, has given a recent speech, Thanksgiving speech, where he didn't mention COVID at all. Mark, you can ask.
Look, I guess just maybe in closing, we've talked about a lot of things today, but I guess in the setting of a new president coming into an absolute disaster, apparently he's already begun chatting with Scott Morrison and getting advice about how we have managed quite a different situation, I suppose, but what things could be transplanted to the US, or just a situation anywhere that's less controlled. What do you think, in closing, are the things that we have really learnt from this at a high level in terms of what have been the successes of our pandemic response?
I mean, from an Australian, I mean, it's easy in Australia because we're a small place on an island, but the reality is, I think leadership and community engagement are critical. Basically, if you've got two sides saying to do different things, you're going to lose. So hopefully Joe Biden can get the community on side and get consensus on, an approach. What we've shown is that you can stop the virus, even with community transmission. And the way you do it is by severe social restrictions and distancing. And it is possible to stop with a good public health infrastructure. Now, I think America could do that. Whether they want to do it or not is another thing. It comes at an enormous economic and social cost. So that's a decision. But if at the very least, they need consistent advice from their leaders and consistent buy-in by the community. They would be the two biggest single things that they can do, apart from maintaining good public health infrastructure and surveillance.
And I think we've had a mix of good luck and good management. We haven't seen the hyper level of division and partisanship that has happened in the US, although we have had our version of that, and disagreements between federal and state governments. But I think overall there's been an attempt to try and bring those together, and we had this whole national cabinet, which was the forum for trying to get a cohesive response. So I think we're fortunate because of our, as Peter says, our natural advantages, being a relatively small population on an island and with fairly stable and cohesive government.
Something Australia did quite well was Australia decided to trust the science. And I think most Australian governments invited clinicians in to help make decisions. And I think that's a big lesson. So I watched the way Anthony Fauci's been treated in the US. That very much contrasts to the way our senior medical clinical decision makers have been valued and treated in Australia. So at every level of government in Australia, there's been a series of clinical and scientific advisors, and they've been trusted and they've had a public voice. And I think that's been a real positive that, Australia has decided that we trust science, and that hasn't been the case in the US, where actually some of the science and some of the clinical advice has been actively disregarded and ridiculed in the media.
That contrasts with Australia's approach to global warming.
Yeah. Yeah, I do.
You can't have everything, Sanj.
Something we didn't mention was the evidence task force, which I think is just been brilliant in terms of stopping stupidity. If you look at what's happened in some countries, with all sorts of crazy treatments, and this happened during SARS too, by the way, in Hong Kong. People would say you should do plasma exchange or some bullshit thing, because someone survived after having it. And so the evidence task force was relatively cheap. It was a couple of $1 million. They got all the various experts from around Australia together in different subgroups, pediatrics, geriatrics, whatever. And so all that feeds to a summit nationally, and basically the level of evidence is categorised, and unless there's, level 1 evidence, it's not recommended, apart from in a trial. And people have followed it. There has been virtually no disagreement at a national or state level about that, which is unbelievable. When you think about it internationally, it's just fantastic.
So I hope that we can take that approach, Peter, and tidy up the rest of our clinical guidelines. There are currently 7 DKA guidelines that apply to my department, so bring it on.
No, I agree with you. I think it's a fantastic model.
But also the clinical councils as well. So in New South Wales, very early on, a statewide clinical council was established with a representative from each. Admittedly, it wasn't every specialty at the start. It almost is now. But what a valuable thing to have 50 senior representatives of their specialty sitting around talking to the upper tiers of New South Wales Health about what to do. It's been great. We should keep doing it.
Well, we might close it there. This has been a really fascinating and informative discussion. I'd like to thank you all for joining us. It's been really, really good. Peter, Claire, Matt, you've been fantastic, and keep up the good work. For everyone else watching, we're going to try and keep doing the odd video from time to time to keep you interested. We're still working, hopefully, towards Africa in 2022. And fingers crossed, we hope to see you there.
Excellent. Thank you, everyone, for coming, and thanks for listening.
Bye-bye.
Thanks, guys. See you soon. Bye.